All right, guys. Well, it's just ticked over to 6:30, so we'll start tonight's session. Thanks again for everyone for joining for tonight's Grand Round session. Tonight, we're joined by Dr. Patrick Disney. He's a local cardiologist from the Royal Adelaide Hospital, and he specialises in adult congenital heart disease. He also works privately for Genesis Care. He's going to talk to us tonight about transthoracic echo indications and uses, and also a little bit about the coronary CT at the end there. No, we're really privileged to have Patrick. He's a really nice guy. So hopefully you enjoy the session. If you have any questions, just chuck it in the chat, and we'll try to get to it at the end, or if it's really urgent, we'll get to it along the way. I really hope you enjoy it. We've also got Sian Goodson here, the Director of Clinical Services from South Australia. She'll be monitoring the chat as we go along as well. So I'll hand over to Patrick.
Right. Well, thanks so much, Jarrod, for introduction. Thanks for everyone for sort of joining tonight there.
Now.
So look, as Jarrod mentioned, a couple of talks that I'll be going through, a couple of topics there. The first on echo, which is my area of interest, and then a second one on CT coronary angiography and perhaps risk stratification from that.
I'm not too bad.
So hopefully you'll get something from a couple of talks, and happy to take some questions at some stage there.
Sure we do work.
So as Joe mentioned, so I've been at the Royal Adelaide and private Genesis Care for the past 20 years or so, and as I say, echocardiography, my main interest, and adult congenital heart disease as well.
Yes, just the arrow down.
We'll see if I can get to the next one there. We'll see if I can.
Didn't work.
If not, we'll get there in a second. Because my first one was probably just about, is there a page down?
Yeah, so yes. That'll work now.
All right. So just to go over some of the common indications for transthoracic echo that you might come across in general practice. And I think the important thing to know when to think of ordering an echo, and perhaps what are some of the significant findings that should prompt your referral on to a specialist. And this was a talk I'd given a little bit earlier this year. We had, at that stage, I talked a bit about some of the changes in the MBS echo regulations from a couple of years ago. Look, that can be something we can either talk about or not talk about in the questions there, if that's of interest to anyone. So more this was going to be about probably echo itself there. So just some of the common things that you would come across there, so murmurs and dyspnea, breathlessness, and hypertension and family screening, I thought I would touch on there briefly, and a somewhat topical thing of vaccine myopericarditis, which just some thoughts on my perspective on that. So as far as murmurs go, so I think from a general practice perspective, most murmurs probably warrant an echo. It does depend on your sort of confidence in your auscultation skills, and that obviously varies across people depending on their training and how much they've seen there. If you're pretty confident, you've got a really soft murmur, what we might call a grade 1 on 6 murmur with there's no other signs or symptoms of heart failure or any other concerning symptoms. Look, to be honest, that could be watched clinically, and you could listen to that, and if there seemed to be a change, then you could order an echo. It may well just be a soft flow murmur, particularly a pregnant woman or a young adolescent there. But I guess your aim is to try and detect a significant valvular or other sort of cardiac pathologies there. So what are some of the things we look for? So aortic stenosis will be one of the most common things in our population. So the nice sort of panel A there shows a nice thin leaflet, tri-leaflet aortic valve. The leaflet should be almost translucent there. They're that thin. And then on the right, the panel B, there is a rather calcific, degenerative tri-leaflet aortic valve. Lots of thick nodules of calcification there, and would be causing significant restricted leaflet mobility and severe stenosis. And so the things that I think are worthwhile you're looking at from a GP perspective and on your echo report. So things like valve areas or aortic valve area, or an AVA would often get abbreviated as. Certainly, and that should be on all good echo reports, there a valve area that's less than 1 centimetre squared probably warrants referral on, because that's probably getting towards the severe range. or a mean gradient, a mean pressure gradient that's more than 40 millimeters of mercury would be taken as likely indicating severe. Now, there are some subtleties to some of those measurements, but I think if you see those, then that probably indicates the valve is severely stenotic and would warrant a cardiology review or input. Now, there is a move to sort of earlier intervention, and there's no doubt the percutaneous aortic valves have significantly changed our approach to aortic valve intervention. A much less invasive procedure, that the TAVI, so that panel there at the bottom showing the catheter valve coming up from the aorta retrogradely through the aorta, and balloons and valves are then inflated in the aortic valve position. So something that really can be done as an overnight procedure or an overnight stay, really there for people. And there is certainly interest in moving towards intervening on aortic valves before people become perhaps symptomatic with severe stenosis, as we have techniques there that are safer than open heart surgery. And so we may start to treat aortic stenosis a bit like mitral regurgitation, which I'll touch on in a moment, where even if people weren't getting any major symptoms but had severe stenosis, that could be an indication for intervention. The other thing for looking at aortic stenosis, the congenital bicuspid aortic valve. So it's the most common congenital abnormality in our population. Probably about 1.5% of the population, particularly males, will have a bicuspid aortic valve. And the panel at the bottom there, that the large picture shows a nice tri-leaflet aortic valve in the middle of the screen. And down the bottom, the bottom left diagram shows a bicuspid valve with the two leaflets seen there. And certainly that has implications not only for the patient themselves, but from a family screening perspective there, because there is a higher chance of some form of congenital heart disease in any relative, first-degree relative of those with a bicuspid valve. So parents or siblings or children, we would generally recommend should have a screening echocardiogram, either to look for a bicuspid valve. Occasionally we do turn up an isolated dilated aorta, and certainly other abnormalities like isolated septal defects we've seen in those who've had families with a bicuspid valve. So just something to keep in mind, that screening beyond just the index case is certainly worthwhile. Mitral valve prolapse, another common cause of murmurs in our population. So the panel on the left there showing a nice normal two-leaflet mitral valve, the leaflets nicely closing there in systole as they should, and on the right they're showing one of the leaflets buckling back or prolapsing, would be the anterior leaflet there, which then results in various degrees of regurgitation. And again, the sort of things that should prompt referral, if you're getting an echo that's saying there's more than moderate mitral regurgitation, or there's signs of left ventricular dilatation or dysfunction, or any arrhythmias like atrial fibrillation, then I think those certainly warrant referring on to a cardiologist. Lesser degrees of mitral regurgitation don't necessarily need to be seen immediately by a cardiologist. There are obviously many other causes of sort of murmurs, and too many to go through. But I think in principle, in general, we'd have a low threshold for having someone referred on for an echo and for an opinion if you're unsure of the significance there. As far as the frequency of follow-up echoes for some of these valve abnormalities, look, hopefully on an echo there might be some indication as to how often an echo should be done. But in general terms, and there are published guidelines on this around the world, and I've just given one reference there, although there are many that are freely available on either the ACC, American College of Cardiology, or American Heart Association websites there. If someone's got mild aortic stenosis or mild mitral regurgitation, look, 3 to 5 yearly echoes at the most is ample. Moderate, probably every 2 years, and a severe abnormality, probably at least once a year we'd be following those. And so I think if it gets to a severe abnormality, that's worthwhile referring on. But otherwise, those lesser degrees, those intervals are probably quite satisfactory. People with mild aortic stenosis or mild mitral regurgitation certainly shouldn't be getting echoes every year. There would not really be a justification for that. Look, dyspnea. So obviously many causes of that, but one of the main things to be on the lookout for was, could it be sort of cardiac failure of one form or another? And I think, again, just a brief explanation of one of the important things for you to look at on your echo reports there. that usually we're making some assessment of left ventricular systolic function. And so the ejection fraction is our most common assessment of that. And so it's worthwhile just knowing, let's say, roughly how they calculate that, sort of what that means. Really, it's just looking at the amount of, or the percentage of blood that the heart ejects every time that it squeezes. And certainly it's not 100% by any means. The normal value is probably 55% at most or more that the heart would eject with every contraction. So the Simpson's rule is our way that we calculate the ejection fraction. So the panels on the right, just some still frames, and whether it's on echo or cardiac MRI or CT, they always use the same method. They just divide up the ventricle into a column of discs there, and you can sum up all the areas of that to come up with a volume in systole and a volume in diastole, and just subtracting that gives you your ejection fraction. And so the normal values, as I say, should be more than 55%. If your moderate is getting usually less than 40%, and that's important because your agents such as Entresto or the SGLT2 inhibitors for Ziga, etc., less than 40% is when we'd consider them as being indicated. And if you get less than 30%, generally that's severe dysfunction, and our device therapy such as ICDs, defibrillators, or CRT for cardiac resynchronization, biventricular pacing would come in at those sort of levels. So I think if you've got someone who's got an ejection fraction of less than 40% or moderate dysfunction, then I think that certainly warrants referral on for cardiology review. Less so as you could be, but certainly moderate, I think most cardiologists would want to see. Hypertension, just a quick word on that. Again, I think most people, you can make an argument for having an echo at diagnosis of hypertension. And a couple of thoughts on that. Although it's unusual, but excluding aortic coarctation, particularly if you've got a young hypertensive patient less than 50. So coarctation being a narrowing of that proximal part of the descending thoracic aorta, as shown on that sort of diagram there, can be quite focal or can be a bit more diffuse. Sometimes has a murmur, sometimes doesn't. So it can be quite silent, and we do sometimes pick it up in people in their 30s, 40s or 50s. And so an echo should usually be able to give you an indication about whether there's signs of a coarctation that might prompt intervention, because it is one of the things that can be a treatable cause of hypertension, be it either with surgery or stenting procedures, which can significantly improve the control of their blood pressure. And the other thing is looking for signs of hypertensive heart disease, where they've got left ventricular hypertrophy or dilated atria or a dilated aortic root. So the panels on the right, that the two top ones showing normal left ventricular size and wall thickness. So the cavities in the chambers are labelled there, and nice thin walls and a nice sized aorta and a normal sized left atrium. The bottom panels show somewhat more of a hypertrophied ventricle. So particularly the bottom right, what we might call a short axis, where the left ventricle looks like a donut there. The walls are a bit sort of thicker than normal. And I think if you see signs of those, it just helps inform you about perhaps when you should be starting medication for them. If you've got a newly diagnosed hypertensive who has signs of end organ damage or changes in their heart, then I would tend to say that commencing medical therapy sooner rather than later is warranted. If you don't have any signs of that, and so long as their blood pressure is not horrendously high, there could be a trial of lifestyle measures for that group. But it can just help inform you and the patient as to when they should perhaps start something if needed. Look, family screening and cancer surveillance there. So if you have patients who have sort of cardiomyopathies there, be it a hypertrophic cardiomyopathy or a dilated cardiomyopathy, we would recommend that their first degree relatives should have a screening echocardiogram to look for similar abnormalities there. The interval is variable, but probably at least every 5 years we would say it's worthwhile, up until the age at which the index case was diagnosed. Now, there's a bit more genetic testing available for some of these conditions, and so that can be quite useful in letting you know if anyone does need longer term follow-up and screening. But in the absence of genetic testing, that some sort of regular echocardiogram is certainly indicated and useful. And again, if that picks up abnormalities, then sort of early referral for a cardiology review would be appropriate. a word about cancer survivors, and certainly something that we see, those particularly with childhood cancers who've had leukemia or lymphoma and perhaps had quite high-dose chemotherapy, maybe less likely radiotherapy, but that is something else we look out for, that there is certainly a risk of them developing left ventricular dysfunction with quite a severe dilated cardiomyopathy, sometimes more than 20 years or more after their treatment. And so this can be in their 20s or 30s that occasionally we see them turn up with significant left ventricular impairment. I think there's more awareness now amongst the hematologists who are treating children, and so they tend to be screened and followed up. But if you do have people who've had previous therapy and they perhaps haven't had an echo at some stage, then it's certainly a very simple thing to do. And certainly if they're having any symptoms of breathlessness, just to bear in mind there could be a cardiomyopathy they could be developing. The other group that we're seeing is those who've had some of their various treatment for breast cancer, etc., like Herceptin, where there can be more of an acute cardiomyopathy that develops early in the course of their treatment. And again, that can be mild in some or more severe in others. A treatable cause either with cessation of their Herceptin treatment or medical therapy with some of the traditional heart failure treatments is certainly useful. So again, but there tend to be quite well-organised screening programs for people going through that sort of treatment. So it should be picked up by the oncologists and perhaps what you might call the cardio-oncology services that are available nowadays. To finish off the echo talk, perhaps a word on vaccine myopericarditis there. So I certainly know that many people think they have had it, and it's certainly a lot of awareness amongst the community about it, and a lot of concern amongst sort of people. It's certainly real, and I've certainly seen some cases through the Royal Adelaide that we've had, but it is rare. It's predominantly been in those young adolescent men under 30 years of age. Rare reports outside of that age group, but that's really been the predominant group. 15 per million in this age group, so uncommon, and typically after their second dose of their Pfizer or Moderna vaccines. Have not seen it, obviously, with AstraZeneca or with the Novavax vaccine, so it seems to be specific to the mRNA vaccines. Pericarditis is certainly one of the things that people can get. We would look for perhaps their ECG changes, but usually their troponin will be normal. They may have a pericardial effusion, a small effusion on an echo, but they'll probably have normal left ventricular function. We'd see on their ECGs that fairly typical, fairly diffuse ST segment elevation there. So in this ECG, through lead 1, lead 2, lead 4, 5, and 6 across the chest leads, that sort of scooped ST segment elevation doesn't really look ischemic, so more typically pericarditic. So that will be the typical thing that we see. For those who might have developed myocarditis, where there's been some extension of inflammation to the myocardium, usually in that group we would find an elevated troponin. That would be one of the hallmarks of a myocarditis. Their echo, look, it's certainly indicated if you see someone who's got an elevated troponin and recent vaccination, then an echo can certainly be very useful. But their left ventricular function may be normal by their ejection fraction measurement. You may not see much on that. There are some techniques, more highly specialised techniques that are available on many echoes, not every echo, with a strain measurement, which allows us to assess the myocardium in a bit more detail. And there are some patterns we see on that when people have had or do have vaccine-induced myopericarditis. Probably cardiac MRI is our most useful test for that. Really gives us some excellent pictures of the myocardium. This is one MRI picture, which is sort of taking a sagittal or side view of the heart, and the left ventricle would be that black donut type shape in the middle. The white is the blood in the left ventricular cavity. The more triangular shaped structure on the left is the right ventricle. There's a nice arrow sort of pointing there. You can sort of see a spherical, maybe quite spherical white line, almost like a tram track actually. One longer line on the outside, and then a smaller, shorter white line or white area of enhancement inside that. The one to the far right is the pericardium lighting up with inflammation, and then the smaller area of a white signal in the middle of the left ventricle well, it's on the right side, is more the myocardium. And so that the MRI is very sensitive for picking that up. It's obviously not available to everyone there, but that is what we tend to use for diagnosing these conditions. It almost always resolves either spontaneously or with various forms of medical therapy. Certainly here in South Australia, I'm not aware that we've had a fatality from it. We've had the very rare one that's been quite unwell, but they have all improved. But certainly it's something that's out there, but rare in most. So I think,
questions.
yeah, so that was mostly for the echo talk. So happy we can answer a few questions that popped up before I move on to the CT one there.
Sounds good. So a question from Lucy: how reliable is BNP compared in ruling in or out heart failure, and when's it indicated?
So but BNP is certainly a very useful in the acute setting of evaluating sort of breathlessness there. And if you have a normal BNP level, then it would make it very unlikely that, that you're going to have significant heart failure as the cause for breathlessness. If it's abnormal, then it can be a little bit more difficult to interpret. It usually indicates heart failure, but things that can confound it, if people are in atrial fibrillation, even with preserved ventricular function, they can have elevated BNPs. Sometimes people with renal impairment, their BNPs can be elevated in the absence of a significant heart failure. So useful in a way of perhaps trying to rule out significant heart failure as a cause of breathlessness in the acute situation. If it's abnormal, then yes, further investigation is probably warranted to try and determine the significance of that. So that's where an echo would be useful to see if there's systolic dysfunction, diastolic dysfunction, valvular heart disease, that sort of thing. But if it's completely normal, that can be reassuring.
You can order a BNP and get a Medicare rebate?
No, so we can't. So
You
again,
can't?
no. So it's similar. So in the emergency department, one can, but it is a sticking point there. That so it's not something that I use a lot there in general routine sort of practice.
Okay.
In the hospitals, it is available a bit more there. So in the public hospitals, they have the ability to measure that more readily there. But in private, it is an issue because there is a cost to the patient for that, which is not huge, but it is a bit of a barrier to routinely using it.
Yeah.
Mm.
Yeah.
Mm.
Okay, cool. Is there an increased risk of developing atrial fibrillation with finding of a dilated left atrium echo?
Yes, is probably the simplest answer there.
Mm-hmm.
And although it does depend on what might have caused the atrial dilatation, as in your valvular regurgitation, left ventricular dysfunction, so heart failure of one cause or another. But there's no doubt if you've got enlarged atria for whatever reason, you're just at more risk of developing probably any form of atrial arrhythmia, atrial fibrillation or atrial flutter, maybe less likely SVT, but arrhythmias are more common with atrial dilatation. So it's something, if you have that on an echo, then you're on the lookout if patients start to report sort of palpitations, that a low threshold for trying to catch that in some way on monitoring in one form or another.
Apple Watch is any good for that, or not really?
Look, I have to say, I mean, there is a lot more people coming in with the wearable devices there, and I think that they are pretty good at measuring the heart rate, and in the case of the Apple Watch, the heart rhythm, I'd have to say. So certainly for people find if they notice all of a sudden a rather fast, irregular heart rate on their watch, then that can be an indication of some sort of arrhythmia. And the Apple Watch with the ability to record an ECG, the tracings are not bad that I've seen. So I think they can be quite useful, I have to say there, because we all know that your holter monitoring, trying to put something on for a random 24-hour, 48-hour period is a low yield in many of this sort of groups. So having people being able to monitor it themselves, and then if they start to pick up something abnormal, that might help lead you down the road of a certain diagnosis.
You mentioned surveillance echocardiograms for people that have, genetic disorders like hypertrophic cardiomyopathy.
Yes.
Is there an age where you'd start that? Because I see kids coming in and their parents have had it. At what point do I start the echocardiogram screening?
So partly would depend on symptoms. Obviously, if someone had some sort of symptoms there, then you'd have a low threshold for checking them out. So, for example, a child of a parent who had a hypertrophic cardiomyopathy, if they'd had a syncopal event, during exercise or something, then sure, you would start then at that point. otherwise, I think you can make an argument certainly by late teens, once people sort of finished growing there, or by early 20s, that I think it's useful. Certainly in the case of a bicuspid valve, well, it may just be one echo that they need. It's sort of there or it's not there. And for the hypertrophic or dilated cardiomyopathies, I probably don't feel we have to put children through echoes that routinely. Not that it's a really traumatic test to have there, but it can be a little bit anxiety provoking for some young ones there. But by the time people have finished growing, so I'd say for end of adolescence, certainly by 20, I'd say for most then starting a screening program. And I try and tie it in with a certain age, then it sticks in their head, so sort of 20, 25, 30, 35, that sort of thing there. Then that can often just help people remember when they should probably prompt themselves to get checked out.
A couple more on the chat. Is new onset right bundle branch block in an asymptomatic patient an indication for an echo?
To some degree, a tricky one. I mean, I'd have a low threshold for saying yes if it's a new onset sort of right bundle branch. It's uncommon for us to see major abnormalities with right bundle. Like a left bundle branch is different, and I would say that certainly should prompt an echo if you see that appear on an ECG. With a right bundle branch block, we'd be looking to assess the right heart. Rarely, we might turn up an atrial septal defect, and a right bundle branch might appear later as there's stretching of the right heart. Be uncommon that you pick up pulmonary emboli that way, particularly in an asymptomatic sort of person. So I think just because echo is such a easy thing to do, but gives you a lot of information there, that I just have a really low threshold, and sure, you could say I'm biased being a cardiologist and loving echo. But I think there's little to be lost in a way if you're seeing something different electrically or symptom-wise there to having one sort of simple echo. If it looks fine, then I think you're reassured, no, there's nothing unusual going on. And most right bundles, then we would almost ignore for the rest of people's life there. And so there's no need for a regular follow-up there at all.
Great, thank you. Another one here. We often get reports back stating impaired diastolic relaxation profile. Is this akin to diastolic heart failure?
Yeah, look, diastolic heart failure is a whole other talk in itself, really, there, and something that's been, well, it's a common question that comes up there on echoes there. So I think it's where the clinical context is important. So mildly impaired relaxation would be consistent with mild diastolic dysfunction. Now, in many people, that's not particularly significant or not, that doesn't cause symptoms for them. If people have more moderate diastolic dysfunction, and there are various ways that's graded on the echo, then moderate diastolic dysfunction tends to indicate that left atrial pressures are probably rising, and so people would probably be getting some degree of breathlessness with that. So I think if you've got someone who has some breathlessness, you're wondering if they have heart failure, you have an echo, it maybe comes back with mildly impaired relaxation. I mean, they might have diastolic heart failure, but I'd be more convinced or suspicious if it came back with moderate or severe diastolic dysfunction. Then you'd be more convinced that was likely a significant finding. Most mildly impaired relaxation, we don't tend to worry about too much. There's a lot of that we get reported on echo, and probably most doesn't have particular significance, particularly if people are asymptomatic. It becomes more relevant the more symptoms people have, the more structural abnormalities they have on their echo, left ventricular hypertrophy, impaired systolic function, valvular disease, dilated atria. Then it can become more relevant as an isolated finding. If there's nothing else they've commented on, I'd almost ignore that if someone was asymptomatic.
Okay, that's good. Okay, do elite athletes warrant cardiac review or echo?
So let's say that there are various programs around the world, and certainly if you get to that very elite level, that many sporting programs would be sending their athletes for routine echoes. So the Italians have been very active in that space for a long time, and have done screening echoes on all of their highly competitive athletes. The evidence for that as a broad screening program perhaps hasn't quite been there for let's say for other sort of countries to adopt that. Again, a very low threshold for doing an echocardiogram. So anyone who has any unusual symptoms of palpitations or syncope or pre-syncope definitely warrants an echo. any sort of abnormality on an ECG, we'd say would warrant an echocardiogram there. So if people are completely asymptomatic, no unusual family history, completely normal ECG, often the guidelines would say that they don't need to have a screening echocardiogram, but again, a very low threshold for doing it, because it is, we do see it, the hypertrophic cardiomyopathies do just sometimes turn up that way with their syncope on the pitch or competing somewhere there, and so it does turn up occasionally with no other warning. So no, it's not definitely routinely recommended, but so here in Australia, not necessarily, but if there's any abnormal symptoms or ECGs, then absolutely. No one would call you out if you sent off an elite athlete for an echo just to check. Really, there would not be much to be lost from that.
Okay. So I don't have many elite athletes in my cohort patients. That's good.
Oh, they're around, yeah.
Okay, last one on the chat then. Is there a role for obstructive sleep apnea patients being surveyed if nothing abnormal at diagnosis, particularly with risk factors? That's from Lachlan.
Look, again, no definite guidelines on that, but there's no doubt with sleep apnea, things like atrial fibrillation are more common, and potentially pulmonary hypertension and sort of right heart failure. So it would depend, I think, again, on the symptoms from your patient, how well their sleep apnea was controlled there. Someone who's perfectly well controlled, has no symptoms of right heart failure, no arrhythmias at all. There doesn't seem to be let's say, a guideline to say that they must have a regular echocardiogram every 5 years or so. But again, a low threshold. So breathlessness that people aren't quite sure of whether that's cardiac or not. Some signs of peripheral edema with leg swelling, any palpitations. An echo useful to look at the right heart and see this size of the right heart, atrial size, pulmonary artery pressures, just to see if there's anything that does need more closer review or specialist referral. So again, not routine, but any symptoms or signs, then again, a low threshold for it.
Does obesity affect the views you get on echocardiogram?
It can do, and so there's no doubt that the larger people are, then sometimes the more technically difficult it can be to get all the information there. It's variable. You do get some large people who do have great echo windows there, but generally on average, certainly as you get to the more morbidly obese sort of group there, we do struggle a bit to see more things like subtle wall motion defects there. You can usually get your signals for valve dysfunction or pulmonary artery pressures. It may just be that looking for signs of an old infarct or something might be sort of more difficult.
And do you know if our Indigenous population has a greater risk of congenital heart disease, or is it the same as?
Look, there's not been a lot of work in that area, but there's been some studies through sort of Central Australia, Northern Territory, where there may be a high risk of congenital heart disease there in that group. Again, screening, antenatal screening is probably not as good as it is for those people who live in the major towns, and so things may not get picked up quite so early there. So I think on balance to say that there probably is a slightly higher risk, but difficult to quantitate how much that is there at the moment. It's been quite small studies that have been done on that so far.
Okay. All right.
I guess the only other thing is access in the public system. Obviously, there's people in different states here. Is there fairly easy access, or are there long waiting lists generally in public hospitals for echoes?
Oh, look, I'm sure it would be variable, and I'm sure there would be wait times at sort of many. So I know certainly here in South Australia can be quite significant wait times of many months for an outpatient sort of GP referred echo. And I'm sure that would be duplicated around the sort of states, as the hospitals are sort of struggling to deal with their own inpatient sort of population there and their own outpatient population, that doing echoes from GPs probably gets difficult for many of the departments there. So it is an issue about access to studies, and obviously people having it out in private is a cost in some situations there. So it is difficult, and I'm sure that's duplicated around the country.
Any tricks for getting through triage quicker for GPs?
Look, no, because I know even my patients have difficulty reaching me through the Royal Adelaide there. It's it's a bit of a maze sort of trying to then negotiate through the administrative thing. So it is difficult, and let's just try to highlight an urgency to it in some way, and highlighting an urgent symptom. But it can be really difficult.
Okay.
Okay, thank you.
All right, thanks so much. Shall we?
All right. Well,
If there's no more questions, I reckon we'll move on to the
the CT, which was a short sort of talk on CT coronary angiography, and perhaps some thoughts on where it sort of sits in from a, let's say, a GP perspective there. So to talk over just a couple of things about CAC, which is a coronary artery calcification, or a calcium score would be more commonly known to most of you, and CT coronary angiography, and I guess when perhaps to think of ordering these tests, and the implications of the results. And this was a job one of my colleagues had sort of put together, and at that stage was maybe how we could help access these tests. Obviously that's a local thing and would depend on what access you have to those in your local institutions there. So to go through the evolution of coronary artery disease over the years. So obviously the arteries start off normal with a nice thin endothelial layer, and then a medial layer, and then the outer layer, so just seen in a cross section there, and then gradually over time you get the little fatty streaks developing, so seen at the bottom there, often beginning in the second decade of life in our population, so really early. And then you start to develop a bit more progressive atheroma there. Often this will be completely asymptomatic at that stage. It's not flow limiting, so stress testing at that point will look completely normal. But then you perhaps progress then to the more severe stenosis, which then that will be causing angina. Often maybe quite stable though at that point if it's been a slow accumulation of plaque and a gradual stenosis. Or you can get what we call the vulnerable plaque, which is rather difficult to predict. So where there's quite a lot of inflammation, and then that acute plaque rupture and the sudden development of thrombosis and occlusion of the artery, which is pretty much the cause of the acute coronary syndromes that we tend to see. So in that group in the bottom there, where they get gradual progression of narrowing and symptoms, stenting will certainly help their symptoms. Not a lot of evidence that changes their prognosis, so stenting is very good for symptoms at that point. For those with acute plaque rupture and acute coronary syndrome, we know that stenting does seem to improve their survival, certainly if people make it to the cath lab. There's obviously a significant percentage where that is their only sudden sort of cardiac fatal event, which is obviously one of the main things we're trying to avoid. So it's we need to identify perhaps those patients, so you can sort of treat those with the somewhat more primary prevention earlier on, so they don't progress to particularly those at that acute plaque rupture stage. So perhaps the asymptomatic patient there. So a typical one, a 60-year-old, used to smoke, has been hypertensive, but that's controlled now pretty well with blood pressure of 130. Hyperlipidemia, a total cholesterol of 5.5, so not horrendous, and an LDL of 3.4, and a good HDL, perhaps not diabetic, but a bit of a family history there with a father and brothers having cardiac events at what you consider a rather youngish age, 50s and 60s, and this is a common group we get coming to us, and probably a bit more commonly now, I think a few, since a few high-profile people with their cardiac events, people wondering, are they at risk themselves? And so if you use some of the various sort of calculators that are around it, probably this is probably not quite sort of formatted sort of properly there, so I'll try and interpret it for you there. But if you use some of the calculators that are around, like the Australian National Vascular Disease Prevention one, it might suggest that is it somewhat sort of low risk there, maybe sort of 9% over the next sort of 5 years. Whereas if you used an American Heart Association calculator, it might say, well, it could be 12% over the next 10 years, which they might consider it sort of high risk there. The issue is that neither of these calculators will be able to take account of the family history. That's just not able to be seen in or not able to be accounted for in either of these calculators. So that's always the unknown. Perfect. No, that's right. Perfect. So what is useful? So this is where coronary artery calcification, even though it's quite a crude sort of scan, is very good at helping to further risk stratify people, even across these sort of traditional risk factors. So I think if we look at this graph here,
I'll just
Yeah.
Patrick, I'll just interview guys. Can you just make sure you're muting your screens there? Yeah.
over there.
Anyone else is sick at home as well?
Yep, still hearing someone
Go on.
over there.
I fixed it. There we go. All right, now back to Patrick. Sorry about that.
So this is just a graph sort of showing perhaps what people's event rate on the far left, you have to say per 1,000 patient years, that the number is not necessarily important, but obviously the higher the number, the higher their risk. And then on the bottom there, look at what would be sort of 0 risk factors or 1 risk factor or 2 or 3 risk factors, traditional risk factors that we take account of. And then on the right side, look at what their current, what someone's coronary calcification score would be from 0 through to 100 to 300 or more than 300. So, it's a no-brainer that those are at the far left of this very small green box there at 0.6. If you've got no risk factors and you've got a very low calcium score of 0, you're at very low risk for cardiac events over the future. And equally, those on the far right in red, the box at 34, sure, if you've got lots of risk factors and a very high calcium score, then sure, you're at high risk for cardiac events. I think probably the more useful ones are probably these group. So if you have 0 risk factors, so traditionally you might think that you're at low risk, but you have a calcium score that's over 300, that really puts you in a rather high risk category of that sort of 10.9% of cardiac events in the future. And equally, the box on the far right, if you have 3 risk factors, and we normally consider, well, this person must be at high risk of cardiac events in the future, but if they have a calcium score of 0, it actually means they're probably at very low risk there. And so that's really one of the advantages we find of even the simple crude coronary calcification. It can really help risk stratify people within these groups there. And it is highly predictive of mortality there. So that this graph of survival over time and with your calcium score on the right. So if you have a calcium score of less than 10, then you're pretty much right up near the top. You should have very good prognosis. But the higher calcium score you have, right up to those who have scores of over 1,000, which are very high, then really quite significantly increased cardiac events and mortality over that time. And that's for people with the same number of risk factors there. So if you have a calcium score of 0, it's likely that there's not going to be any major detectable coronary disease. If you've got 1 to 100, it's probably mild disease. Sometimes this is a bit relative depending on people's age. So some people, young people who might have a score of less than 100, that could still be quite high for someone who might be in their 40s, and so we might still consider them to be at somewhat higher risk. And obviously, as you go up in higher degrees of calcium score, the much more likely you are to have extensive atherosclerosis. So it's a marker of perhaps the extent of coronary atherosclerosis, but it won't give us information about how severe any stenosis will be. And so if you've got someone who actually has any symptoms there, chest pain or anything you think could be a cardiac symptom, probably a calcium score is not the test to be organising there. They should be having something else, be it stress testing or a CT coronary angiogram. So it's, I guess, for the asymptomatic patient to assess their risk, that's where the calcium score really has its place. So if you have a score of 0, you're very unlikely to have a significant stenosis, probably less than 1% in some of the large published series around the world, and you're very unlikely to have a heart attack, less than 1% chance over 15 years. So it's a very good prognostic sign in itself. So, the Cardiac Society has incorporated this into one of its position statements a few years ago there, so back about sort of 5 years. And so probably the place where it sits, so if you work down from the top there, they are still saying, well, you use your risk calculators to try and assess people's risk. If they seem to fit into the low risk group on the far left at less than 10%, look, perhaps so long as they don't have any strong family history or other factors, at the moment they might recommend, well, they perhaps don't need any further investigation or treatment. But if there is a family history in that group or something else that concerns you think is a risk factor, then a calcium score can be very useful in stratifying that risk. Equally, to go to the far right and those who are at high risk, then look, probably they warrant treatment anyway. But there are certainly those who are hesitant or reluctant to commence medication, and certainly a calcium score in that group can be quite useful, because if you can show people that they've got things building up in their coronary arteries, it's very persuasive, I find, in encouraging them to commence, well, lifestyle measures and antihypertensive treatment and statin sort of therapy. There's nothing like showing people a score and showing them something is a problem there to make them take notice of it. But it's probably the group in the middle, the medium risk group, where that perhaps sort of 10 to 15% risk of a cardiac event over the next 10 years. That's where coronary calcification scores really can be very useful to help you determine if they are the lower risk or the higher risk, and help determine treatment. So that is certainly a recommendation from the Cardiac Society there. And obviously, depending on the result, well, then you can work out if you need to treat them there. If they're less than 100, then generally they don't need treatment. As I say, there would be some situations in a younger patient where a calcium score of less than 100 could still be significant, and we might still consider treating those. But certainly over 100, things like statins and antihypertensive treatment, lifestyle measures are certainly warranted. So this is probably one of the caveats of the calcification, coronary calcification, that it will not pick up non-calcified plaque. So here a CT coronary angiogram. So the left ventricle is on the left, and on the right, that long pipe is probably the left anterior descending artery, and the arrow nicely points out an indentation in the coronary artery, so it gets quite narrow, and the white dye comes down to a trickle through there. So, probably a moderately significant stenosis, but there's no bright calcification at that point. It's all black soft plaque indenting the artery. And so in that group, their coronary calcification score would be 0. And so that is where I'll just go back on that there. So we just have to be careful about reassuring people too much if they have a completely normal coronary calcium score, particularly in those, certainly under sort of 50. So in those who might be sort of 40 there, that the calcium score does have some limitations there. So if you have someone who is perhaps symptomatic but potentially stable, so it's where you're getting to this choice between sort of exercise, stress testing, stress imaging with things like stress echo, myocardial perfusion scans, the nuclear scans, or CT coronary angiography. And so the differences between these, so I guess on the one hand, one is going to look at the anatomy, so the CT coronary angiography, we try and look at the anatomy of the coronary arteries, whereas the other stress testing will be trying to assess whether there's ischemia present or not. So on the left, the anatomic test, yes, you can be assessing for potentially even subclinical disease. It is certainly very accurate, a highly sensitive test, but if you get an intermediate sort of stenosis, perhaps a 60, 70% narrowing reported on a scan, sometimes that can be significant, sometimes it can't. And so a CT at the moment in routine practice can't assess that at this stage. If someone has a very high calcium score, that can sometimes make it difficult to see the lumen underneath the calcification. And so people with very high calcium scores, it can be very hard to see what's happening in the coronaries underneath that, and you can get rather indeterminate results from that. Ischemic testing, yes, you do get information about people's functional capacity. You can see if they develop symptoms with exercise. You can determine if they might have a large burden of ischemia, if there's a large area of the left ventricle that may be getting ischemic. You can assess the significance of a borderline lesion. So people have a moderate or moderately severe stenosis on some form of other imaging. Stress testing can help work out if that might be ischemic. But stress testing can be normal in people who might have extensive but non-critical disease. And so stress testing can certainly miss things in some people there. So just to highlight that, here are two cases which would both show normal exercise stress tests. So on the left is a coronary artery that largely looks sort of fairly normal with no major narrowings in it, no major calcification, really looks quite normal. On the right, all those bright white areas of calcification. There's some dark areas of non-calcified plaque. Nothing that's severe, but there's quite extensive atherosclerosis. But a stress test, I say, will look completely normal, but there's very different implications for those patients, a very different prognosis. So yes, the one on the left, we have a calcium score of 0, high quality angiogram, less than 1% risk of an acute coronary syndrome in 15 years. Excellent. This one, calcium score over 800, diffuse non-critical, but certainly quite a lot of calcified and non-calcified plaque, and really quite a higher chance of cardiac events. And the CT is all done, I guess, there with quite a low contrast dose and really low radiation exposure nowadays. The way they take the scans is certainly much improved with much lower radiation doses. And one of the studies that has been done around the world, the SCOT-HEART study, which was reported a couple of years ago. So if you add in a CT coronary angiogram, even after stress testing for sort of chest pain, so someone's had some chest pain, they've had a stress test, perhaps even if the stress test looks normal, if you add in a CT scan, you will pick up sort of people who might actually have more significant disease and will lead to better intervention. So there was quite a significant reduction in death and non-fatal myocardial infarction in the group who had the CT coronary angiogram, which then changed management significantly and resulted in an improved prognosis. So look, it's not that sort of one test sort of fits everyone there, I guess was what this was sort of meant to show there. So look on the left there, if you've got sort of perhaps a low, we'll look at that preferentially considered if people have got maybe a low clinical likelihood of severe stenosis, and if they're people who you hopefully should get a high quality scan. I mean, if they're morbidly obese, that can limit some of the accuracy of the stress of the CT. People with atrial fibrillation, it can make it difficult to get a high quality scan because of the irregular heart rate. People where you can't slow the heart rate down to a slow rate may get a lower quality scan. So long as you've got local people who can do high quality scans, then the CT coronary angiogram is certainly a very useful test to do. And that might lead to sort of drug therapy. If people have ongoing symptoms, then we've got a low threshold for invasive coronary angiography there in the middle of the screen. If on the top right there, maybe you think people may well have cardiac disease, and you think perhaps your revascularization might be sort of likely there, then the stress testing to assess the burden of ischemia can be quite useful in that sort of group to then decide if they need to go on to sort of angiography. And obviously, if people have an angiogram and it shows significant disease, well, then we stent them or revascularize them in sort of some way. So the tests may all get used in the same patient there. You may have someone who has some equivocal chest pain there. A CT scan suggests some potentially moderate or disease of uncertain significance, and then we'll go on and do stress testing in those. If the stress test is abnormal, we'll move on to an angiogram. If the stress test is normal, well, then we continue with sort of medical therapy and a conservative approach there. So I think how to sort of interpret results there. So if people have got a 0 calcium score, and certainly if they've got a normal CT coronary angiogram, very low chance of cardiac events over the next 10 years. Very reassuring for people there, particularly those with sort of family histories. People who have perhaps some mild to minimal disease, a calcium score that's less than 100, no stenosis is over 50%. Look, certainly that can be quite reassuring. It can still be appropriate to be talking about sort of risk factor modification, and particularly in younger people. And if they were younger people with a bad family history or a high cholesterol, we'd still think about referring them on, because we might still think about treating them a bit more aggressively. Obviously, those who've got more moderate disease, perhaps 50 to 69% sort of stenosis, which get to be moderate. It's usually got to be more than 70 or 80% to cause ischemia. But in that moderate range, we would look at considering stress testing, and probably stress echo imaging would be the most common thing that people would do to assess the burden of ischemia. And as mentioned, if there was no signs of ischemia, we'd continue with medical therapy, and certainly they should be considered to be referred on, if they haven't already, to a cardiologist. If it was obviously an abnormal stress test, then they should definitely go on to be talking about angiography. And those who've got more than 70% disease or extensive disease, largely we'd probably be going to angiography in that group. And so they certainly should be sent on for cardiology review. So calcium scores and CT coronary angiograms, look, just becoming increasingly used, and we're just finding them increasingly valuable in just taking out some of the guesswork of trying to work out who might be at higher risk or at lower risk. And I think that a lot more than just the normal risk calculators that we have. and they provide a lot of very good prognostic information that continues to accumulate. And so I think that guides us a lot in how aggressive to treat people. And there's, although it's not mentioned in here, the cardiac side I think is certainly considering. There's been some talk about whether repeat scans are worthwhile in people. So there's some every 5 to 10 years where we do look at repeating coronary calcification or CT coronary angiograms to help guide us on whether we're really slowing down atherosclerosis. A brief note, everyone's calcium score will increase as they get older, but it can be a matter of whether you can decrease the percentile that they're in. So for their age and sex, for someone who might initially be in quite a high percentile, a higher risk, there's certainly some people where you can slow down the accumulation and bring them back more down to more the average normal percentile there. And so that can be quite useful to guide us in our therapy. So I think that was it. There's a few questions coming up, so perhaps we'll see what comes up from there. Thank you.
Fantastic. Not quite sure I get this one. How would you feel that a symptomatic patient should have a stress test and the CTCA? Question.
So I think Louis, that's a group where you're right. You've got the choice of either there. I think if I had the choice, that it probably well, it would depend on maybe your suspicion about the likelihood of disease. So, for example, if someone had a really highly suspicious sort of story of angina, really typical, often we'll just go straight to an angiogram there because we think it's highly likely we're going to find something. If, let's say, you're not quite so suspicious that it's a high likelihood of angina, look, to be honest, often I would probably tend to go to a CT coronary angiogram in sort of many people if I've got the availability to do it, so long as we can get a good quality scan, just because you get a lot of information from that. If the CT comes back as showing an intermediate stenosis, potentially suggesting a moderate or moderately severe stenosis, then often I will put that person on the treadmill for a stress echo to look for ischemia. And as mentioned, if they've got ischemia, we'll then go on to the angiography. If they don't have ischemia, then we'll continue to treat them medically. But there are some people who can't have a CT scan for one reason or another, be it contrast allergies or atrial fibrillation, or you don't have access to that. And in that case, stress testing is certainly very reasonable. And then if stress testing is abnormal, again, then sometimes, depending on how abnormal the stress test is, in some of those, we might say, well, if the stress test was a bit equivocal, we're not really highly suspicious, I might think about doing a CT in that group then. So I think generally I would probably prefer now to do a CT because I think we get more information from that, and then I might do stress testing after that.
Okay. And we don't always get much choice in this as GPs. Often they go to chest pain clinics and they just get the stress test and then they come back to us. I don't know how much we can recommend from that position. No, and
it is difficult. And you'd say, look, if you're looking from an economic perspective there, that there probably isn't a guideline or advice that CT as the first port of call is worthwhile. I think it's probably the most accurate test, and so probably we would tend to use that as cardiologists. But from a GP point of view, given the limitations at the moment on ordering CTs without attracting the Medicare rebate, that stress testing is a very reasonable test to sort of do. I think, look, we'll see whether things change in the future. I know they would be looking at opening up, GP referrals for CT coronary angiography, and I think that will be a huge change. And sure, it may be a large cost, but it probably has the ability to lead to further cost savings there, so that you're accurately identifying the group who does need treatment there. You're minimising perhaps inappropriate angiography from equivocal exercise stress testing. So there could be an economic argument in the future for more use of CT coronary angiography. I think it's probably headed that way in the longer term. But at the moment, I appreciate there are limitations on GPs being able to organise that thing.
Any more questions from anybody? Because that's all I've got for now.
Well, CT angiographies are pretty quick too, aren't they?
Look, they are. I mean, the time in the scanner is probably only a minute or two there, because it's sort of one heartbeat to sort of capture the images. So most of the prep time is getting a cannula in, getting people up onto the table into the scanner, fast picture, and then you're out. And then people usually observe for half an hour or so afterwards. They're really rare that we see allergic reactions to contrast dye, but definitely reported. And so I think obviously CT scans are done in sort of different places there. important that there's the facilities around for treatment of anaphylactic reactions if sort of needed there, but that's very rare, and so most do tolerate it very well. And so most have a protocol for giving doses of a beta blocker, perhaps in combination with an agent like ivabradine or Corolan we commonly use. So our protocol here is a dose of a beta blocker the night before and the morning of the CT scan, just to try to get the pulse rate down to 50, 55 beats per minute, where then they get the highest quality scan, as it's gated to the QRS. If the heart rate is faster or with potentially with fast atrial fibrillation, then there can be a bit more movement artifact, which can limit the accuracy of the test. So if someone's in rate controlled atrial fibrillation and you get their heart rate down to that sort of rate, then CT is still quite a reasonable thing to do. But a very fast scan and well tolerated. So it is revolutionising sort of what we do. There's no doubt.
And you mentioned exercise stress echoes. Are they actually treadmill echoes? Like where you get them on? Don't you do drug induced echoes as well?
So correct. So you can do both. So pharmacological stress testing for those who can't exercise on a treadmill for one reason or another, and that will be the same for nuclear scans. So treadmill or pharmacological thallium scans or nuclear scans is an option, and does depend on local availability. Generally, we try and put people on the treadmill. You get a lot of functional information from just seeing people on the treadmill, and so for a stress echo imaging before and immediately after being on the treadmill is quite a straightforward thing to do. Again, touching on what you mentioned, people have to be able to exercise on a treadmill. And also, again, people who are, some people who have difficult echo windows there. So a really large overweight person there, we may struggle to get really high quality images on a stress echo, and you need to be able to see the left ventricle to make an interpretation. So that does, again, there are limitations to the accuracy of, and be it stress echo and nuclear has similar limitations. With those who are quite overweight, they do get some false positives there.
Yeah, and I mean, I know Genesis Care do CT coronary angiography in South Australia, Queensland and Victoria.
Correct.
Yeah,
correct.
With
and
good access.
Yes.
I wonder what you do in Tasmania, Lachlan. Do you have CT coronary angiogram down there, Lachlan? Just to throw them on the spot.
Just coming off mute, yeah, thanks. I think a lot of it's through specialists only. I'm aware down here. I'm not aware of it being available by GP referral.
Okay.
So it would be available there, but you're right, again, like here, mostly from specialist referral. Although, some people, some patients are prepared or want to pay out of pocket themselves, so we do see that, but generally, you're right, it might be better, well, not better, but to save people sort of money, say, well, do they go on and see a specialist and then go on? Obviously, it depends on the gaps for specialists there as to what the cost works out to be there. So you have that discussion, but some people are prepared to pay for it themselves.
Yeah. All right. Well, if there's any more questions, if there's no more questions, it's not about it. Oh, good. Well, thanks so much for your time tonight, Patrick. They were both fantastic. They were both spot on. They were great presentations. You added a lot of value to our doctors.
Sort of on time.
Spot on time. Spot on time.
No, fine. No problem. No problem. I guess happy if there's questions that come sort of later there, but otherwise, if there was something.
Yeah. Okay. All right. Well, then we'll call an end to the proceedings, guys, and we'll see you next time. Thanks, everyone, for joining us tonight.
All right. Night there.
Bye.